All right. So before I proceed to the other bits of investigation, any questions? I mean, I know the acid-base balance thing is a little bit confusing, but if there's any specific parts you want me to go through, I can just hit it again and then we quickly try to wrap up. So are we okay? Can we go on?
Yes, sir.
All right, okay. So we also talked about alpha-1 antitrypsin, and we said, as the name suggests, antitrypsin. So it prevents activity of enzymes that break down proteins. So there's an investigation we can do to check the alpha-1 antitrypsin levels of the patient, and that gives you an indication of how bad things are going for the patient. Of course, there's a cough, so you try to pick up the sputum and then you'd analyze the sputum as well. And you do a chest x-ray, and a CT scan would actually show you that the alveoli is destroyed. Okay. So how would you manage your patient? It's very, very important that your patient stops smoking. Because when you're treating patient is still smoking, condition will get worse, and you can even have decompensation happening during that time where your patient keeps smoking. So you just have to pay close attention to that. And then, of course, just like the chronic bronchitis, it's good to put your patient on bronchodilators. And with that, we said they are preventers and then relievers. Okay, so can go back and then check. And then you put the patient on steroids as well. Okay, so they start with prednisolone and then eventually they would go on to the Symbicort and Seretide that we talked about. Always good to give antibiotics, especially when clearly there's an infection. Then your culture and sensitivity will guide you. You put your patient on some cough syrup because we said that they might have some sputum stuck there. You need an expectorant to get rid of it. You give your patient oxygen, but you always have to be mindful when you are giving oxygen. You try to wean the patient off. You don't let your patient become too dependent on oxygen, because that means that it gets to a point where you need a patient to get off the oxygen. The patient has now become dependent on oxygen. Okay, what happens is for the body, the drive for the body to go into respiration is dependent on the carbon dioxide levels in your blood. So once the carbon dioxide level starts going up, your respiratory centers become hyperactive, and then you start breathing to get rid of the carbon dioxide. When you put your patient on high flow oxygen to the extent that they lose that carbon dioxide sensitivity, then they get into a state whereby they are not able to trigger that respiration, because carbon dioxide has been diminished totally in the blood, because you basically pumped this patient with high flow of oxygen. Okay, and high flow of oxygen also comes with other toxicities where it can basically cause problems with the retina aspect of the eye and all that. So we have to be mindful when we are giving oxygen, and that's why we always monitor with our SpO2, and then we try to gradually wean patients off the oxygen. Okay. And the last disease condition we'll touch on is bronchiectasis. So you can see that today we've basically gone through almost all the aspects of the airway. We started with the bronchus, and then we went to the terminal bronchioles, or the very, very small bronchioles, and the alveoli. We are coming back to the middle. This time around, we are going to be looking at the medium and small side bronchi, and then the bronchioles. Okay, so we are looking at the bronchus, but we are basically not looking at the main bronchus, like what you find in bronchitis. We are actually looking at the bronchioles and then the smaller size bronchus. Okay, so bronchiectasis. Bronchiectasis is basically a condition in which almost 100% of the time, or most often, is secondary to an infective process. Okay, it doesn't just develop. Almost every time is secondary to an infective process. And the thing about bronchiectasis is it has signs and symptoms which are close to what you tend to see in TB. So one of the differential diagnoses for tuberculosis is bronchiectasis. Okay, so we'll be seeing it shortly. So what happens here is that whereas in your emphysema, you have destruction of the alveolar and terminal bronchioles without fibrosis. Bronchiectasis, we are looking at your medium-sized bronchus and then your bronchials and all that. There's a destruction and then there's fibrosis. Okay, so there's destruction and there's scarring. So you can see that the cilia or the inner aspect, the cilia on the inner aspect or on the mucosa, which in our previous discussion, we said that it beats the microorganisms, the dirt and everything out so that it can be able to cough it out, becomes compromised because that inner aspect of the mucosa has now become scarred and fibrosed. So your cilia is basically gone. So you are making which your lung is unable to propel up and then expectorate because you have zero cilia action in there. Okay, so in the end, you have airway which is blocked by thick viscous fluid. Okay, most of the time secondary to an infection, and this is like a vicious cycle. When we say vicious cycle, one cycle starts, it goes on, and whilst it's ending, it makes the process even worse. Then it continues again. So in this case, you have an inflammation of your bronchus and then the bronchioles. It's leading to destruction of the bronchus and the bronchioles and destruction of your cilia. Once your cilia is destroyed, you have trapped sputum or lots of secretions in there in the airway. Now you have bacteria colonizing this secretion. Then they have another cause of infection, destroys, causes scarring, loss of ciliary function, then excess secretion in the lung, then another bout of infection. So it keeps going round, where you have a cycle going on, and in this cycle you have excess sputum production there, stuck in the airway, infection, destruction of your cilia, and then excess secretion goes on round and round and round and round. And that's why we say it's a vicious cycle. Okay. So you can see it's a vicious cycle of infection. And this infection here is because of the secretions, scarring, and then permanent dilatation of the bronchial wall. Okay. So ideally, when you do your X-ray, you won't see much. But when you do a CT scan, the diagnosis for bronchiectasis is a chest CT scan. That's the gold standard. Once you do a CT scan, it would show you clearly that there's a permanent destruction of the airway. Okay, so the common causes usually, as we said, it tends to be related to infection. So people who have this might have had chronic childhood pneumonia. They might have had some TB in the past. They might have had COPD, rhinosinusitis, so many diseases, okay, over there. Cystic fibrosis is there because in cystic fibrosis, there's an impairment in the cilia action. So once cilia is not functioning well, then you're going to have excess secretion in the airway. Excess secretion would cause bacteria to colonize that excess secretion you've got over there. Then there's an infection. Infection leads to inflammation. Inflammation would result in scarring. Scarring will lead to loss of cilia, and then it goes on and on and on. Okay. And people whose immune system, they have some sort of deficiency in there, are also at risk of bronchiectasis. Symptoms similar to what we've been talking about all along, but this goes a little bit close to TB. So they have fever and night sweats, okay, similar to what we tend to see in TB. They cough, and when they cough, there's blood in it. So, I mean, once you don't have your investigations properly done, you might mix a TB for a bronchiectasis. So you can have a case where the patient is coughing and all, night sweats, fever, weight loss, and then there's blood. You do a gene expect and all that, and it's negative, and then you go like, oh, this could still be TB. Okay, but then the patients will rather tell you that, well, I haven't been in contact with someone who has been coughing for a very long time. So, I mean, and I haven't been in an overcrowded space, so I don't think that I have TB. But however, when I was young, I used to get lots of pneumonias. Okay, so that should be drawing your attention to something. Then you know that, all right, okay. I mean, yeah, so this could be a bronchiectasis. We do a chest CT scan, and then it would bring it clearly out. You see that the getting to the distal aspects, your smaller and medium-sized bronchi, and then your bronchioles are all dilated and then destroyed with fibrosis. Okay, so there's fever, there's clubbing, which you also see in TB. And remember, when we're talking about TB, we said TB is a form of pneumonia, right? So once you percuss, it will be dial on percussion. In this case, so when you percuss, it's going to be dial. When you listen, you're going to have a bronchial breath sound and cause crepitations like your usual pneumonia and TB. Okay. The investigations, we said that chest CT scan is the gold standard, but there are other investigations that we'll do for like almost every upper respiratory tract infection. You want to do a full blood count and try and get some of the sputum out for culture, always key. If the patient doesn't have a chest CT scan, you do a chest x-ray at least, I mean, to look out for consolidation and all that. Once you find a consolidation, you know that, all right, okay, you're dealing with a pneumonia. But if your mind should go towards the direction of a bronchiectasis, you always need to be sure of your diagnosis. So a chest CT scan is a gold standard, and then it is the way to go. Okay. The treatment here, unlike TB, where the microorganisms are very stubborn and difficult to treat, so you need that long periods of treatment with those funny antituberculous medications. This time around, your usual amoxicillin and azithromycin will sort you out. You can start treating with that whilst you await your culture and sensitivity for a directed therapy. Okay, then you need to open the airway, just like all the other two conditions we've been talking about today. So bronchodilators would help, corticosteroids would prevent inflammation. So that would reduce the scarring and loss of cilia. Then it's always good to make sure they are eating well, okay? And chest physiotherapy and all that, very, very essential. Once they undergo chest physio, they are able to, work on their breathing exercises, cough, sputum comes out, and they are good to go. And then in severe disease, where there's an issue with oxygen getting into the tissue and all that, you have to put your patient on some oxygen whilst you monitor your SpO2. Okay, so we've been talking about three main disease, bronchitis, which we said we have acute and chronic. And then with acute, we said most of the time it would arise after an upper respiratory tract infection, which is mostly caused by a virus, and then later you have a secondary bacterial infection. Okay, then we talked about chronic bronchitis and emphysema, and we said that makes up COPD. The key feature here is that you've got air trapped in the airway, and so there tends to be an expansion of the airway. So when you do your imaging, you're going to see an expansion of the lungs, sort of. And because of this expansion, when you percuss, it's hyperresonance. And also when you percuss over the solid structures like the liver and the heart, you are going to have a loss of the dullness of liver and the heart. And that should tell you that there's an issue going on there. Management, mainly you start thinking about asthma because you want to open the airway, you want to give steroids, which we've talked about, and it's always key to give antibiotics to treat any form of infection. Then we talked about bronchiectasis. We said bronchiectasis is similar in presentation in a way to TB, okay, and the symptoms and then the features that you would see on history taking and an examination tend to be a bit similar, but your investigation is what will differentiate a TB from a bronchiectasis. We said your gene aspect will tell you if you're dealing with a mycobacterium tuberculosis or not. Okay, gene aspect comes, it's fine. Differential bronchiectasis, chest CT scan comes, it shows you dilatation of your small and medium-sized bronchos and bronchioles as well, with distraction and then fibrosis and loss of cilia. The CT scan is able to see all that. It tells you that, and then clearly you know that you are dealing with a bronchiectasis. Then you manage the patient. So any question? I hear you have another class at 2, but if you have any questions, we can quickly take them before we go. And then hopefully tomorrow, if it will be possible, Nick, you can arrange for us to have another session. We do the pleural and the pulmonary edema in the evening when everybody is comfortable. Okay, so any questions?
Yeah, Doc. This question escaped me when you were doing the TB. The night sweating, usually what causes the night sweat?
What causes the night sweat? It's because of the temperatures. You see, every disease has a certain temperature pattern it follows. Okay, so of course, there's the general temperature pattern where someone is sick and then constantly the temperature can stay at maybe 39 degrees Celsius throughout. The person is sick and has a temperature of 39. The person is sick and has a temperature of 40 throughout. Okay, so they have patterns like that. And you have diseases that come with a swinging temperature. So sometimes the temperature starts maybe at 37. So when you plot, and then you realize that with time, this temperature that started at 37 keeps going up to 39. Okay, and then all of a sudden the temperature drops on your next check. Okay, and then you go and check again, the temperature has gone up. So it gives you an idea, oh, okay, the temperature is swinging. When the temperature is swinging, means that most likely you are dealing with some abscess or a condition where there's pus and all that. So we have different patterns of temperature. Sometimes you have malaria and you realize that you only get very hot during the night. Okay, so the pattern of the temperature, and you know sweat comes with heat, right? So the pattern of the temperature and all that would predict when you sweat the most. And with TB, usually the night sweat will come with a very, very high temperature at night. And that's the reason why they tend to sweat a lot. Okay, it's all about it's all about temperature patterns when you're dealing with such infective cases.
All right, thank you very much.
You're welcome. Welcome. So I'm sorry for, I wanted us to finish early so you can prepare for your next lecture. I've taken all the time. So I'll communicate with Nick, and then hopefully tomorrow or Tuesday evening, we can have another lecture. Okay.
All right, Doc.
To try and read through this, put your questions down, and also go through the acid-base balance I was trying to. That was just by the way, but I'd wanted you to understand that point in the slide, but try and go through it. Once you understand that principle, most diseases you'll be coming across will make lots of sense to you, especially when you have acid-base balance in there. Okay, so you read through and let me have your questions the next time we meet, and then we'll take it from there.
All right, Doc.
Okay. All right. Enjoy your Sunday.
Thank you, Doc. You too.
Yeah. All right. Okay. Bye.